The medical history is the single most powerful diagnostic tool in clinical practice, directly contributing to an estimated 70 to 80% of the final diagnosis. It is far more than a simple questionnaire. It is a structured, professional conversation with a therapeutic intent. To understand the patient's unique story, build a robust diagnostic framework, and, most importantly, establish a foundation of trust. This process is the cornerstone of the clinical relationship, profoundly shaping patient satisfaction and their future adherence to treatment plans. Success begins in the pre-interview phase by setting the stage. First, ensure your environment is private, quiet, and comfortable. Minimize physical barriers. Sit at the patient's level and avoid standing over them or being separated by a large desk. Begin with a professional demeanor. Introduce yourself clearly with your full name and specific role. Confirm the patient's identity using two identifiers, such as their name and date of birth. Then, practice good agenda setting. State the purpose and estimated length of the interview up front. You might say, "I'd like to spend about 15 minutes understanding what brought you in today. Does that sound okay?" Now, initiate the interview with effective opening techniques to build rapport. Start with an open-ended, non-directive invitation. The best opening is often the simplest. "Tell me what brought you in today." As the patient begins to speak, practice attentive silence. Use supportive nonverbal cues like nodding, maintaining an open posture, and appropriate eye contact to encourage their narrative. Crucially, avoid interrupting the patient's initial statement. Allow them the first 60 to 90 seconds, the golden minute, to express their concerns without interruption. The interview follows a core structure, beginning with the chief complaint. This is a concise, direct quote of the patient's primary concern, recorded faithfully in their own words. For example, "I have a crushing chest pain," or "This headache won't go away." The central pillar is the history of present illness, the HPI. This is the detailed, chronological story of the chief complaint. It is where you will spend the majority of your time piecing together the diagnostic puzzle. To master the HPI, we use the OLDCARTS mnemonic as a systematic framework for comprehensive data gathering. O stands for onset. Ask precisely when and how the symptom began. Was it while you were resting or exercising? The context of onset is often diagnostically key. L is for location. Identify the exact anatomical site. Ask, "Can you point with one finger where it is?" Always inquire if the sensation radiates or travels anywhere else. D is for duration. Determine how long the symptom lasts when it occurs. Is it constant or episodic? Distinguish between pain that lasts for seconds versus hours. C is for character. Elicit a qualitative description. Ask, "What does it feel like?" Encourage the use of similes, such as "like an elephant sitting on my chest," or "a burning sensation." A is for aggravating and alleviating factors. What makes the symptom worse? Movement, food, stress? What makes it better? Rest, a specific medication, or a certain position. R is for radiation. Does the sensation travel? Learn classic patterns like pain radiating to the left arm or jaw in cardiac issues, or to the back in pancreatitis. T is for timing. Understand the pattern over time. What is the frequency of episodes? Is there a relationship to specific activities, meals, or times of day? S is for severity. Quantify it using a 0 to 10 scale. Equally important is assessing functional impact. Does the pain stop you from working or sleeping? Next, we must expand the clinical context by exploring associated symptoms and conducting a review of systems. First, ask directly about symptoms that are pathophysiologically linked to the chief complaint. For chest pain, this includes shortness of breath, sweating, palpitations, and nausea. Then, perform a review of systems. This is a systematic screening of all major organ systems, cardiac, pulmonary, gastrointestinal, neurological, and so on, to uncover hidden clues and complete the clinical picture. While you will focus on systems relevant to the presenting problem, A brief screening of all systems is a vital safety net. To understand the patient fully, we explore their background through past social and family histories. The past medical history includes all chronic conditions like hypertension or diabetes, previous hospitalizations, and major illnesses. Include a relevant obstetric history. The past surgical history lists all procedures, their dates, and any associated complications. Document all medications meticulously. This includes prescription drugs, over-the-counter medications, supplements, and herbal products. Always note the dose and the patient's actual adherence pattern. For allergies, document the specific medication or allergen and the precise nature of the reaction, whether it's a rash or full anaphylaxis. The social history provides a holistic view. It covers occupation, living situation, diet, exercise, and critically substance use, including tobacco, alcohol, and recreational drugs. It also includes sexual activity, recent travel history, and an assessment of psychosocial stressors. The family history involves constructing a brief pedigree. Focus on heritable conditions in first and second-degree relatives, such as coronary artery disease, diabetes, specific cancers, and autoimmune diseases. Advanced communication involves responding to emotion and eliciting the patient's own perspective. When a patient expresses fear, frustration, or sadness, respond with empathetic statements that acknowledge their feelings, such as, "That sounds incredibly frustrating." Actively elicit the patient's perspective using the ICE model. Explore their ideas about what is wrong, their concerns about the illness or treatment, and their expectations for the visit and outcomes. Always assess health literacy and tailor your explanations. A powerful tool is the teach-back method, where you ask the patient to explain back to you what they understand. Closing the interview effectively is as important as opening it. Begin with summarization. Briefly recap the key story elements to ensure accuracy. Say, "Let me make sure I have this right." Then, offer a final invitation. Ask, "Is there anything else you were hoping to discuss today that we haven't covered?" This open-ended question often reveals critical information. Finally, provide a clear transition. Explain the next steps. "Next, I will perform a physical exam, focusing on your heart and lungs based on what you've told me." The process culminates in documentation. The history must be recorded in a clear, organized, and objective manner using standard medical terminology. This written record is the permanent foundation for your clinical reasoning, essential for communication with other healthcare providers, and a vital medical legal document. Thank you for watching. Don't forget to like, share, and subscribe. See you in the next one.